So this is just a representation of some of the sex differences. Here is a graph on your right of age in years on the x-axis and prevalence on the y-axis. The upper graph is females, whereas the lower graph is males. And you can see that around the start of puberty, you get a dramatic increase in the prevalence of migraine headaches. In women between the ages of 20 to 40, you start to get a prevalence that approaches about 30% of the population. So a large percentage of females within this age range actually develop migraine headaches. And you can see the takeoff in females as compared to males, particularly during early adulthood, during childbearing years. And the observation that a migraine prevalence increases after puberty, particularly in females, and the gap between males and females widens during early adulthood. And you can see a drop-off in prevalence after menopause, suggests that there may be not only sex differences in migraine, but that gonadal hormones may also play an important role in migraine biology. There are different phases to a migraine attack. So we know that migraine is not only the headache disorder, even though we focus very heavily on the headache. Migraine is a very complex syndrome. And so some patients will describe days before the headache starts a prodrome. This doesn't occur in all patients, but in some patients, they will experience irritability, certain food cravings, fluid retention, increased yawning. A proportion of patients will develop aura symptoms, and I'm going to talk about that in a little bit more detail in a few slides. The headache is what we know about, and this causes disability that can last 4 to 72 hours typically, but in patients that have status migrainosus, for example, it can last for up to even a week. And then after the headache is aborted, either with medications or spontaneously, patients can actually describe these intense postdromal symptoms of fatigue and hypersomnolence that we really don't have a good handle on, that also lead to increased disability in patients and an inability to return to work and return to normal functioning. Really why it's been a focus of mine in my most recent efforts in the lab. So this is actually, I think, a very nice description. It's an old description of migraine aura from John Fothergill in the 1770s and was published by Hubert Airy in his descriptions in the 1870s. And he was talking about his symptom of what sounded like a visual aura. And here he writes, it begins with a singular kind of glimmering in the sight, objects swiftly changing their apparent position, surrounded with luminous angles like those of a fortification. Giddiness comes on, headache, and sickness. So it sounds like he was having a visual disturbance. Clearly it was changing over the course of the visual field. And then afterwards, he developed headache, and it seemed like he developed a sickness that likely represented some type of gastrointestinal symptoms as well. The most typical form of migraine aura is visual in nature. So patients can describe a crescent-shaped hatched lines. Sometimes they're glimmering or shimmering objects. Sometimes they're colored, sometimes they're not. And this will often expand and progress gradually outward towards the peripheral visual field over the course of minutes. And usually this positive symptom can be followed by an area of obscuration or even a scotoma. And this usually lasts for about 15 to 30 minutes. And oftentimes the beginning of the visual aura event starts before the beginning of the headache. This occurs in about 20 to 40% of migraine patients. Females are more likely to develop migraine aura symptoms as compared to males. Similar to migraine without aura, there's a female predominance. And migraine with aura is also associated with other comorbid conditions and more severe disability as well. Visual aura is not the only type of aura symptom that we find. Patients can also have chirooral symptoms or sensory symptoms. This can start, for example, with a tingling in the fingertips that can progress slowly into the hand. This can then march up the arm and forearm and into the face. So we can see these additional symptoms accompanying migraine as well. Some patients will even have a language or a motor related transient symptom that is suggestive of an aura event. We know that migraine with aura is also associated with a twofold increased risk of ischemic stroke, particularly in young women. So this is a very complex disorder and a very important disorder for us to be able to model and understand for our patients. So how do we take this complex disorder with all of its different phenotypic characteristics and take it into the lab to be able to understand some of the mechanistic underpinnings of migraine? How do we take the complexity of the disease and implement a model that will enable us to be able to identify targets for therapeutic intervention? Well, for monogenic forms of migraine, those that cause sporadic hemiplegic migraine or familial hemiplegic migraine, it may be easier to do, right? You can certainly express mutations in animals. But for the polygenic forms of migraine, those that we more commonly encounter in the clinical setting, that is far more difficult to think about in terms of how we model the disease in the preclinical setting. And oftentimes what we are left with is modeling component parts of the disease in order to examine certain aspects of the disorder that we then piece together to be able to understand how mechanisms of migraine might occur in the human condition. The goal of animal models are to increase our understanding, of course, of migraine biology. Importantly, we want to identify targets, ion channels, neuropeptides, their receptors, in key brain regions and in the peripheral nervous system that may be involved in migraine. We want to be able to generate new therapeutics, right, to provide some optimism for our patients. And I think that the story of the CGRP small molecule blockers and monoclonal antibodies are a key example of how this type of targeted approach from in vitro and in vivo models to target identification and translation can really provide hope for the field of headache medicine. And it required decades of study. So let's talk a little bit about what we know about some of the neurobiology of migraine. A migraine is thought to be, the initiation of migraine is thought to depend on the activation of trigeminal nociceptors that innervate meningeal tissues. These nociceptors have their cell bodies in the ophthalmic branch of the trigeminal ganglion. And this is actually work that initially started with Harold Wolff in the 1940s. And Ray, this is actually a great publication, long publication, but a great publication to read. And in this publication, he reported that stimulation of various blood vessels in and around the meninges can actually produce a referred pain with similarity to the migraine pain that patients experience. And it was one of the first times that it was evident that the structures, the coverings of the brain can actually produce headache pain that was very similar to that of a migraine. And it was likely these structures, either the vessels or the nerves that innervate them or the connective tissue components, that actually was responsible for producing a headache. At that time, Wolff thought that it was the blood vessel that was important, but we now know that there are nociceptors that surround these blood vessels that likely become activated and sensitized during the course of a migraine attack. The meningeal tissues are actually richly innervated by primary afferent nociceptors. And this work has been published. So this is whole mount tissue of the meninges. And this is staining for calcitonin gene-related peptide, which is a nociceptive neuropeptide that we now target for migraine prevention and actually also for the abortive treatment of migraine. And you can see that the meninges has a rich supply of CGRP-like immunoreactive nerve fibers. In addition to that, there are also sympathetic nerve fibers as well. CGRP is released during the initiating phases of a migraine attack. So you can actually measure CGRP in jugular venous blood flow in a migraine patient. And this is work by Sarchielli and others. And the meninges also have a host of immune cells, mast cells, macrophages, dendritic cells, that likely lead to a release of other inflammatory mediators like prostaglandin, bradykinin, and serotonin. And all of these work in concert to produce an inflammation of the meninges once these trigeminal nociceptors are activated. And this produces not only sensitization of trigeminal nociceptors, but also sensitization of second-order neurons in the trigeminal nucleus caudalis or trigeminal cervical complex. And sensitization of both primary afferent as well as second-order neurons are important for pain transmission and eventually the perception of pain, we believe, in the migraine condition. So there are a number of ways to be able to model migraine in the lab, starting with in vitro studies all the way to behavioral studies in the animal. One way that we can look or start to look at migraine in the lab is to look at the primary afferent, those nociceptors that are important for release of CGRP, putatively release of CGRP at the peripheral nerve terminal and centrally at the level of the trigeminal nucleus caudalis. So these neurons can actually be retrogradely labeled by applying a tracer to the meningeal surface. You can remove these neurons, acutely dissociate them, and look at them in the in vitro setting. And when you do that, the actual cell body in vitro is likely a representation of the nerve terminal in vivo, in that the transducer elements that are expressed on the cell body surface in vitro are not typically expressed in the cell body within the trigeminal ganglion, but are more likely to be expressed in the nerve terminal itself. So it actually becomes a very nice model where you can look at ion channels, mechanotransducers, and a host of other ion channels and proteins that may be important for excitability in this specific neuronal population. So let's talk a little bit about what we've learned from some in vitro studies. Well, the first thing that we can do is apply inflammatory mediators, prostaglandin, bradykinin, and histamine to meningeal afferents and examine not only their electrophysiological properties, how do they respond to inflammatory mediators, but what inflammatory mediators actually do to ion channels that are expressed in this specific population. And so here, for example, this is the meningeal afferent, and this is using patch clamp electrophysiology. So this is a meningeal afferent, and here we're increasing current. So this is 1, 2, and 3 times Rio base, which is the amount of current needed to induce a single action potential. and you can see the response for this meningeal afferent. If you apply inflammatory mediators, you get an increased response, an increase in action potential firing in this meningeal afferent. That isn't so surprising. You would expect meningeal afferents to increase their firing properties in response to inflammatory mediators. What was interesting in this particular study was that we observed that 100% of meningeal afferents respond to inflammatory mediators. This is actually quite unique because in other afferent populations, 100% of neurons do not respond to inflammatory mediators. We also found that if we looked at voltage-gated sodium channels in this population, that a slowly inactivating voltage-gated sodium channel that's blocked, that is not blocked by tetrodotoxin, the so-called tetrodotoxin-resistant voltage-gated sodium channels, currents are increased in this population. And so this increase in tetrodotoxin-resistant sodium currents likely contributes to the inflammatory mediator-induced increase in action potential generation in these meningeal afferents. We also found that if we applied inflammatory mediators to meningeal afferents, we could detect an inward current. This current appeared to have a reversal potential that was close to the reversal potential for chloride. And in fact, if we changed the concentration of chloride in our extracellular bath, we could change the magnitude of the current and its reversal potential. So it appeared to indeed be a chloride current. If we applied niflumic acid, which was a calcium-dependent chloride channel blocker, we could actually block this chloride inflammatory mediator-induced current. So this appeared to be a chloride current. And if we applied BAPTA, we could also block this current. And BAPTA is a rapid intracellular calcium chelator. So here we found that inflammatory mediators not only increased voltage-gated sodium currents, particularly TTX-resistant voltage-gated sodium currents, but it also increased the calcium-dependent chloride current. And we later found that this chloride current was actually an excitatory chloride current. So chloride can be depolarizing, but it can provide a depolarizing shunt, in that it can depolarize the cell membrane relative to the resting membrane potential, but it can still be hyperpolarized to the action potential threshold. And so you can have activation of a chloride current that is depolarizing, but still inhibitory. In this case, because inflammatory mediators hyperpolarize the action potential threshold, the activation of the chloride current is actually excitatory in this nociceptive population. We also found that meningeal afferents were exquisitely responsive to inflammatory mediators in terms of their handling of intracellular calcium. So here we're measuring intracellular calcium. This is a meningeal afferent that's been retrogradely labeled from the meninges. So you're seeing the retrograde tracer here, in this case, di-I. This is a non-labeled neuron. This one actually responded to inflammatory mediators. And this is a neuron that didn't respond at all to inflammatory mediators. And when we applied this combination or soup of inflammatory mediators, dural afferents had a robust increase in intracellular calcium that was not only greater than non-dural afferents, but it actually lasted longer than non-dural afferents. And so we're starting to piece together that there are these unique intracellular properties in response to inflammatory mediators in meningeal neurons as compared to other neurons, like those, for example, that innervate the temporalis muscle in the face. We can also learn from in vitro studies how acute migraine treatments might work. So for example, triptans, which are serotonin 1B, 1D, and a little bit of 1F receptor agonists, are effective in aborting migraine attacks if they're given early. Their initial efficacy was thought to be attributable to their vasoactive properties. But we now know that they can act on the trigeminal system. And we know that 5-HT1D receptors are actually expressed in trigeminal neurons. And so this is immunoreactivity for 5-HT1D receptor in the trigeminal ganglion itself. Well, if you apply sumatriptan to meningeal afferents and record voltage-gated calcium currents, you can see a sumatriptan-induced inhibition of voltage-gated calcium currents. This is a dose-dependent inhibition. So here in B, we have time, and here I'm recording the calcium current as an example, and increasing the concentration of sumatriptan. This isn't starting at 0, so you can see the magnitude of change here. But you do see a dose-dependent reduction in voltage-gated calcium currents as a result of sumatriptan. And this is well known. And it's likely this reduction in voltage-gated calcium currents that leads to a decrease in neurotransmitter release as a result of sumatriptan. Interestingly, sumatriptan has other effects on meningeal afferents that's probably not as well known. So for example, sumatriptan can increase potassium currents as well. So here we're measuring outward potassium currents. This is an activation curve. So this is the fractional maximal conductance here on the y-axis, and the voltage here on the x-axis. The gray circles represent inflammatory mediators. This is vehicle applied to meningeal afferents. The triangles represent sumatriptan in the presence and absence of inflammatory mediators. And what we find is that sumatriptan produces a hyperpolarizing or left shift in the voltage dependence of activation of potassium currents, such that for any given voltage, say at minus 40 millivolts, for example, you get a much greater response from potassium currents. And this would likely lead to a hyperpolarization of the cell membrane, a reduction in action potential generation, and an inhibition of neurotransmitter release. So in vitro studies have been really helpful in that they've been able to identify various ways in which primary afferents can be modulated by inflammatory mediators. TTX-resistant currents we know are important for spike initiation, for example. We know that calcium is important for modulation of transducers and ion channels. We know that potassium currents and calcium currents are important for neurotransmitter release. And so most of our in vitro studies have been able to elucidate mechanisms not only that inflammatory mediators may use to sensitize meningeal afferents, but also mechanisms of how drugs may act to block sensitization. But we know that in vitro studies suffer from the fact that they're very simplistic and they don't take into account other neurons that are involved in this process. Indeed, when you remove the trigeminal ganglion, you remove it from its central and peripheral terminal. And in addition to that, you hope that all of the neuropeptides and ion channels are going to be expressed on the membrane for you to be able to record from them. It's a really simplified model. And so it is much better to move to more in vivo studies to be able to examine the impact of disease. And this is done not only with electrophysiology, but also with behavior. So there are a number of ways to model migraine in vivo. Amina Pradhan gave a wonderful talk, Dr. Pradhan gave a wonderful talk at Brigham about the nitroglycerin model, which I won't touch on. There's also a model of CGRP, so you can apply CGRP to animals. You can even give inflammatory mediators directly to the meninges using implantable cannula, and this has been described as well. What I'm going to focus on are models of migraine with aura, which has been what our lab uses. So cortical spreading depression is a slow wave of neuronal and glial depolarization, and it is thought to be the underlying electrophysiological event that actually produces the migraine aura. And this is work that was originated by Arcides Leal right here in Boston. This is an electrocorticographic study in rabbits where he is looking at successive areas of cortex. So he's recording in the cortex. And you can see the electrocorticographic response. And suddenly there appears to be a diminution in the signal from the cortical surface. And this decrease in the signal from the cortical surface spreads to successive or adjacent areas of the cortical surface very slowly over time. And he could elicit this cortical spreading depression event either with electrical or mechanical stimulation. And this was published back in the 1940s. And not only do you see this slow progressive wave, but you can also see changes in the blood vessel that is coincident with cortical spreading depression. It didn't take long before early clinicians looked at the cortical spreading depression that Leo had described and figured that the events of cortical spreading depression matched quite well with some of the events described with migraine aura, and found that the scintillations must represent a phase of intense excitation followed by a phase of total inhibition, and that the timing of the aura event and how it spread across the visual field actually corresponded quite nicely to what Leo had described in rabbit cortex. And it was actually really groundbreaking work by Dr. Nasheen Hajikani, who's in the radiology department, who examined some of this with bold signaling in migraine patients. So for those of you that haven't read this paper, I suggest you read it because I think that it's very enlightening. So in this particular paper, they looked at patients that had migraine with aura. And during the aura event, they were able to take the patients back for fMRI study. And they found that during the aura event, where there was visual disturbance close to the center of the visual field, they could see a bold-related signal in the posterior pole that progressed more anteriorly across the visual cortex in a manner that was corresponding to the aura event that progressed across the visual field. And you could first see an increase in the bold-related signal followed by a decrease in the bold-related signal that again propagated across visual cortex. And the propagation speed actually matched quite nicely with the speed of propagation of the cortical spreading depression event that Leo had originally described. So this was really nice work. So how do we now take cortical spreading depression back to the lab to study mechanisms of migraine aura? Well, we use a lot of methods that were used conventionally to induce cortical spreading depression, both electrical and mechanical methods. So this requires a craniotomy. This requires either creating a burr hole or some form of a craniotomy to either induce pinprick to the cortical surface or to apply high concentration potassium chloride or to electrically stimulate the cortical surface to induce cortical spreading depression. And the SD itself can be measured either electrically as a DC shift potential, or you can measure the blood flow change with laser Doppler flowmetry. But really, it does require cranial surgery in order to do SD induction, at least for the conventional methods of SD induction. So what did we learn from some of these conventional methods? And this is really great work by Michael Moskowitz, as well as work from Rami Burstein's group over at Beth Israel. And what they found was that if you induce spreading depression, you can actually activate trigeminal nociceptors. So here, they've induced spreading depression, and they looked at expression of immediate early gene CFOS, which is a marker of neuronal activation, in the outer layers of the trigeminal nucleus caudalis, which receives input from trigeminal nociceptors, and found that you do indeed get an increase in CFOS immunoreactivity. Then Burstein's group were able to look in the animal and induce pinprick CSDs and actually place a recording electrode either in the trigeminal ganglion or the trigeminal nucleus caudalis and record an increase in electrical activity in the trigeminal ganglion or the trigeminal nucleus caudalis in response to pinprick-induced cortical spreading depression. They even took it a step further and looked at the impact of anti-migraine medications. So again, recording in the trigeminal nucleus caudalis, if they were able to induce a cortical spreading depression event, not only did they find an increase in activity of trigeminal nucleus caudalis neurons, but if they pretreated the animal with a CGRP monoclonal antibody, this actually blocked the CSD-induced increase in activity. And so what we found from some of these models was that, in fact, CSD could activate trigeminal nociceptors, could certainly activate trigeminal ganglion neurons, and it could activate neurons in the trigeminal nucleus caudalis. However, what was lacking in some of these studies was the actual ability to study pain behavior in awake animals. And one of the major drawbacks from some of these studies was the fact that it required cranial surgery. It required a burr hole. And so you had to induce some form of injury to the skull and oftentimes to the underlying meningeal tissue, which is actually the tissue of interest. And so how do we overcome the potential injury from these classical methods of CSD that require cranial surgery? And one way that we were able to do that in the lab is by employing a less invasive optogenetic approach that does not damage the underlying skull, dura, or the underlying brain tissue. And this was really brilliant work by David Chung in the lab, who helped to develop this model for the lab. And what we found was that optogenetic SD is really a feasible model for the study of trigeminal nociceptive behavior. So here, we're able to actually apply blue light over intact skull. So here you can see the skull sutures. So the skull has not been breached. And this is in transgenic animals that express channel rhodopsin 2. And by doing that, we can actually measure the cortical spreading depression event as it progresses across the cortical surface. Here is a laser Doppler fiber, so you can actually measure the blood flow like signal, or you can look at optical intrinsic signal imaging, so the actual reflectance properties along the cortical surface. You can apply a glass cover slip so that this can be done repeatedly over time. And importantly, this is a single event CSD, which is really important because animals can have a single event CSD over time so that you can actually model the chronicity of disease, which is something that we really weren't able to do well previously. So this is an example of what that looks like. There's the blue light, and I hope you can see that there's this spreading oligemia that goes across the cortical surface when you apply that blue light. And this is an image, a video that's sped up by about 20 times, and I'm gonna play that again. So there's the blue light, and there you can see the spreading oligemia that progresses across the cortical surface. And that is the spreading depression related event in animals. So what pain behaviors can we look at in this particular model? Well, one behavior that we can look at is cutaneous allodynia. Allodynia is when pain is elicited from a stimulus that isn't usually painful. And in about 70 to 80% of migraine patients, they will actually experience cutaneous allodynia during the course of their migraine attack. And this is likely related to sensitization of not only trigeminal neurons, but also neurons in higher order centers like the thalamus. So we were actually able to do that in our model. And this is an example of the data. So if we apply a single cortical spreading depression event in animals, we can actually look for the threshold to induce nociceptive behaviors when we give mechanical stimulation around the eye. Allodynia then would be defined as a lowered mechanical threshold for nociceptive behaviors in experimental animals that had an SD as compared to control animals. And all of our behavioral testing was done in individuals that were blinded to the experimental paradigm. So 1 hour after a single optogenetic spreading depression event, there was actually a robust periorbital allodynia in these animals. If you looked 2 days later in a separate group of animals, they completely recovered from their periorbital cutaneous allodynia. If you pre-treated the animals with sumatriptan, you could actually block the onset of this periorbital allodynia in response to single event spreading depression. We could induce SDs, single event SDs, repeatedly over time. So now we're able to model some of the chronicity of migraine as well in our model. So here, a single event SD is induced every other day for up to 12 days. And then we start examining behavior in animals at a time point where in the single SD group, they've already recovered. So here at 2 days, we see a robust periorbital allodynia following repeated SDs. And this is 4 grams, so this is the threshold for nociceptive behaviors. And this is compared to the sham group. At 4 days, they're still allodynic in the periorbital region, so they still have this pain response in the periorbital region. And then this begins to recover at around day 14. And this is very specific to the trigeminal region because we don't see a hind paw-induced allodynia in these animals. We can also look at facial grimace using our optogenetic SD model. Interestingly, facial response to pain is actually quite phylogenetically conserved, and mice actually have a grimace response. And you can measure this as spontaneous discomfort or spontaneous pain in animals. And this is very different from the evoked pain that you measure when you do periorbital allodynia testing. This can actually be combined with fully automated approaches. There are now conventional neural networks that enable you to be able to tell if an animal is in a pain state or not in a pain state. So if we induce a single event SD, we don't find an increase in grimace. But if we induce repeated event SDs over the course of 2 weeks, there is a significant increase in grimace, suggesting that animals not only have an evoked pain phenotype, but also have a spontaneous pain phenotype. So CSD likely triggers head pain via activation of trigeminal nociceptive pathways. And we found also that in our in vivo models, the more frequent SD, the more robust the pain response, which is consistent with what we see with migraine aura. Migraine aura is associated with cutaneous allodynia, and the more frequent headaches, the more severe the phenotype in humans. We were also able to look at other phenotypes like anxiety-like behaviors. And this is really important because we know that anxiety and depression can also be comorbid features of migraine. And we were able to do this in using open field. So here we can place the animal in a large container. They're able to explore openly in this large container, and usually the animals will roam around in this container. So this is a tracing of an animal exploring a large container and the corresponding heat map. If we induce an SD, the animals will tend to only explore around the perimeter near the walls of the container. And this is a measure of anxiety in the animal. And what we found was that repeated SDs, but not single event SDs, produce an increase in the anxiety score, what we call phygmataxis, in these animals. We can also look at short-term working memory using a Y maze where animals alternate between 3 arms of a Y maze. We didn't find any evidence of change in visual spatial working memory, at least in our model, for both single event or repeated spreading depressions. Lastly, I wanted to touch on sex differences in response to SD. We found a strong trend towards lower thresholds, periorbital thresholds, in females as compared to males, particularly when you looked at allodynic groups after 7 SDs. When we analyzed models that not only took into account sex, but also looked at second order a variable, sex times recovery time, we found that sex was significantly associated with periorbital allodynia, and sex and recovery time interacted with one another and was significantly associated with periorbital allodynia in this particular in this particular model. And so there appears to be sex differences in response to spreading depression as well. So the ontogenetic model certainly seems to suggest that SD can produce a pain phenotype, both an evoked and spontaneous pain phenotype. And this likely represents central sensitization, probably of the trigeminal nucleus caudalis, but also sensitization of higher order neurons like thalamic neurons. And we do think that there's likely involvement of other neurolimbic circuits, which produces an anxiety-like phenotype. And there are also sex differences in SD allodynia, which require additional testing. This certainly seems to be a robust and malleable model, which is really important for exploration of mechanisms involved in migraine. So what are the conclusions that we can make from all of these models that we've used, both in the in vitro setting, both in the in vitro, for the in vitro models as well as for the in vivo models? Well, certainly in vitro models help us to be able to elucidate ion channel mechanisms involved in nociceptor signaling. In vivo models are really helpful for us to identify targets as well. They can be used as high throughput screens, this model including others. And they're really important for us to be able to examine the complexity of behavior and central pathways that are associated with the disease phenotype. Future concepts for these models include wireless optogenetics, right? So it's important for these animals to be able to walk around in the cage and be as normal as possible while we're inducing the SD without extraneous variables. And then we can apply things like handling stress or sleep deprivation stress onto our models to see how these things change phenotype. There are other people like Will Renthal working on wonderful concepts like targeted gene therapies. There are those working on nanoparticles, and I mentioned that there are machine learning approaches that we're applying to this. Importantly, we still don't have good ideas about mechanisms involved in psychiatric phenotypes. And one of the major focuses that I have in the lab are mechanisms of sex differences that we see in these models. So I want to end here by thanking those that have really been instrumental to me in my basic science, research career, and those include Michael Gold isn't listed on this slide, and that was an omission on my part. I should have listed him there. But also Cenk Ayada and Jill Goldstein, Ursula Kaiser, Catherine Rexroad, PIs of the Building Interdisciplinary Research Careers in Women's Health program, as well as members of the Neurovascular Research Lab who've been absolutely wonderful and supportive. And I also have to thank members of the John R. Graham Headache Center as well, Elizabeth Loader, Paul Rizzoli, Will Renthal, for their support. And I'll stop here and take any questions.
Thank you so much. For anyone who has any questions, you can throw it into the chat and I can read it off or raise your hand. Let's see. I think Peter Rosenberger has a question.
Thank you. That's a lot of fun to hear that review of a fascinating phenomenon. A couple of historical comments about spreading depression. I remember well in the late 60s, early 70s, when the neurological community sort of came awake to this phenomenon that had been described 25 years earlier. First, was it Leo or someone else who commented that the rate of 3 millimeters per minute was actually that described by Hewlings-Jackson in the march of dysrhythmia across the cortex in focal seizures. And the second is David Hubel of the Harvard Physiology Department, I think wrote a paper or gave a talk documenting the march of visual phenomena across his own visual field in his own migraine.
Yeah, so thank you so much for that question. So with respect to Leo's reference, I am not sure about that, but it very well may have been. And the reason I say that is because it should be noted that Leo was interested in epilepsy, right? And his original that was his original interest when he came here to do his work and to do his study. He was interested in mechanisms involved in seizure disorder. And so it is quite possible that he did make that reference indeed. And some of the early descriptions of migraine aura is actually quite interesting, because if you read John Fothergill's, some of John Fothergill's work and even Hubert Airy's work, they were convinced that that the clinician's description of aura should be taken over the patient's description of aura, and that what we learn from the clinician's description of aura would lead us to mechanism. And so much of what you see published early on is actually the description of aura that clinicians experienced themselves, which is actually quite interesting when you read through some of the early literature. But actually, they describe quite exquisitely the marching and the timing of the marching, which really did help to link the visual percept with what Leo described, because originally Leo did not link it to visual, to migraine aura, right? So I think that some of those early descriptions were indeed insightful in linking the marching and the timing of that marching event to the timing of the CSD that Leo described.
Thank you.
We have another question in the chat. Have you tested whether particular migraine abortive therapies alter pain threshold after repeated spreading depression?
So that is an excellent question. Thank you so much, Priya. So what we did in our model was we looked at single event SD. So remember the purpose of the abortive therapies is to be used after, during the acute attack, right? And typically in the clinical setting in patients with migraine with aura, we tell patients take the medication soon after the aura event to abort the oncoming headache. And so when we looked in the preclinical setting, what we did was we induced the spreading depression event, and then we gave the animal abortive medication, in this case sumatriptan, and then we tested allodynia in those animals, and found that if we gave sumatriptan to those animals, we were able to prevent the allodynia when we tested 1 hour after the SD. So it appeared to acutely prevent the allodynia with single event SD.
And then there's a question about how to attract young investigators into the headache and migraine field.
Oh, that is a wonderful question. Thank you for asking that. So I think that certainly didactics is very important. Introducing concepts related to headache and migraine, particularly in medical school and on rounds, is very important. One of the things that I will say is, for a disorder that has so much disability and affects a large percentage of our neurological, patients that we see, it should be given just as much attention, right? When we talk about teaching residents and having residents see these patients in clinic, I think that it is helpful, in my view, to have residents rotate through a headache subspecialty clinic. That is my view. That is my wish. That is my goal. And it is because of this is a very, very common disorder. And so I think that is one way to do it. We do have other mechanisms, right? So residents should know that there are resident retreats that are put on every year. There's the REACH program here in the United States. In Canada, there are similar programs for resident education you can apply for and go to those seminars. They're dedicated to resident teaching for headache. There's the International Headache Academy as well that people can apply for, and it's, they can get more headache training too. So all of those things are really important. And then there are headache meetings. So here in New England, there's a Headache Cooperative of New England that has a meeting here in Boston every year, as well as in Stowe, Vermont. So we actually have meetings twice a year. And so there are various ways to get involved and get engaged. And really it's up to us as headache medicine specialists to interculate into residency programs in medical school to be able to teach residents and medical students about the importance of knowing about headache.
And then we have another question in the chat. Are there potential new types of medications or migraine treatment that we can suggest based on the current research?
So certainly the CGRP small molecule blockers and monoclonal antibodies are the ones that have come out. Oh, thank you, Dr. Birch. The CGRP small molecule blockers and monoclonal antibodies have come out on the market most recently. And they've provided a lot of excitement for us. They are targeted medications that target this CGRP pathway. In the pipeline, there are people working feverishly on a host of other molecules and neuropeptides like PACAP, for example, that might also play a role in migraine pathobiology. And there are people that are working on neuromodulators too, to reduce medication use in these patients. And so there's a host of research. What I would say is there are a lot of medications that have recently come out and those that are also in the pipeline. There are 5-HT1F receptor agonists that have recently come out too. So there are a lot of new tools that we have in our armamentarium. Despite these tools, we do know that not every patient responds, and we still have a lot to learn about migraine mechanism to be able to really provide robust medications that help most patients with their headaches.
There was another question about how often do you come across people with aura but not followed by a headache?
Oh, my practice is a skewed one, I think. So I come across that quite often, and I think that one of the reasons is because I'm also a vascular neurologist, and so I get the question, is this aura versus TIA? And that is often the consult question for patients that don't have a headache that accompanies the aura. But that is in general practice actually more rare than what we might see in a tertiary center and what I might see as a vascular neurologist and headache medicine specialist. So I see it often, but that doesn't reflect its true incidence.
We learn many ways to help differentiate TIAs versus kind of aura. Is there something that you particularly look to when you're trying to make that distinction?
So the description of migraine is really important, right? This is one of those disorders that doesn't have a readily available biomarker. So we just have to sit down with the patient to get the description. And what I find is that the marching symptom of the aura event is really important. The slow progression over time is also really, really important. And the positive phenomena is really important. And when you have other symptoms, so for example, if you have patients that have visual symptoms and they have sensory symptoms, having one symptom precede the other is actually informative because this succession of symptoms would suggest that there is a disturbance in the cortex that involves successive adjacent areas of cortex being involved. And so you can then invoke mechanisms of CSD in that case. Notably, in large case reports, the vast majority of patients that had sensory symptoms had visual symptoms. So where you should be concerned is if you see isolated motor symptoms or isolated sensory symptoms without visual aura. Those patients I would be concerned about because that rarely actually happens.
Wonderful. Thank you so much. And thank you everyone for attending.
Thank you so much.